Good afternoon, friends. Thank you, Professor Tityal, for having me in the course year after year. One of the basic prerequisites for a safe phacoemulsification is an intact rhexis. And most of the time, the rhexis is intact. However, in certain difficult scenarios, challenging scenarios, which Dr. Ramamurthy has shown, we have a rhexis run out into the periphery, which could become a wraparound tear. So given this kind of scenario, there are three options, three questions to be answered. Do we continue with phacoemulsification in these cases or convert to a safer non-phaco technique? Second thing is, if we decide to go ahead with phaco, then what would be your technique of choice? And third question would be, what kind of lens would you be using? If you're supposing if you planned a multifocal or a toric lens, what would be your lens options? So I'm going to just tell you that it has to be the certain situations where the rhexis tear can be expected. There are certain risk factors, so we need to discuss with our patients beforehand and give them adequate counseling. I'm going to show you a video where rhexis tear happened because the rhexis was small sized and the phaco got a little complicated. So let's see the video. Now this is a 68-year-old female patient presented to me with an intermittent white cataract with a shallow anterior chamber. Patient actually had undergone a past vitrectomy in our center just a few days back. Patient had a silicone oil fill and the cataract progressed rapidly. We advised immediate surgery and patient needed about 5.5 weeks to be ready for the surgery. And the posterior segment surgeon wanted a silicone oil fill. So there are a lot of issues that have to be tackled, that have to be grappled with when you deal with such a complex scenario. I will not discuss those theoretical aspects. And so I'll just show you the video. So now we have planned a two-stage rhexis for this patient. So the paracentesis tracts, side ports on the main incision are plugged with Helon 5. Then gently trypan blue dye is injected into the anterior chamber because visibility has to be enhanced and you need to see the anterior capsule well. And once that is done, if OVD is a soft shell technique is being used and there is adequate viscomydriasis, so there is no requirement for any pupillary device at this moment. So I am going ahead with the rhexis. And just recall that this patient also has another comorbidity. She has a posterior capsular tear, most probably, because the cataract happened and progressed very rapidly, immediately after the vitrectomy. So there must have been, it is a complex vitrectomy, there must have been a posterior capsular damage which led on to the cataract. So patient has an open posterior capsule. So we have challenges here. It is a vitrectomist dye, separate challenges for that. Posterior capsule is open. So now I decided that rhexis was perhaps not enough for me to go perform a safe phaco because the posterior capsule is open. I don't want very high fluidics in the capsular bag, and it is a softish cataract, so I may have to work in the peripheral area. It won't chop, it won't crack. So I thought I'd just dilate. I just enlarge the rhexis into its final size, about 5.5 millimeters. And this point, if you see carefully, if I play the video once again, it was a sort of a deep set eye. It was a deep set eye, and my instrument had been a little vertical. And then once I tried to engage with the scissors, there was a slippage. There's an overlocking, and then there's a slippage, and there's a rhexis tear which happened to the periphery. So injected Helon 5 back again, in the peripheral area. Never do it in the center to start with, and the rhexis has become. It has radialized and it has gone to the periphery, most probably to the equator. So I decided to continue with phacoemulsification in this case. I wanted a larger opening of the anterior capsule, so I just trimmed the dog ear portions of the anterior capsule. Again, went with a different microrhexis forceps and enlarged the rhexis because I want to have a bigger access to the lenticular contents for safer phacoemulsification. When I started phaco in this patient, I realized that the nucleus was very difficult to manage. We could not use cortical cleaving hydrodissection because it was a posterior polar cataract, and we needed to use a non-rotational technique of nucleus management. And here again, I'm stuck. It is neither here nor there kind of cataract. Iris has started prolapsing out, and pupil has become small. And so whenever iris prolapse happens, you should not go from that same incision. You should go from a different incision, preferably 180 degrees away. So then I decided to engage iris hooks. So at this point, one has to be careful because there is always a possibility of engaging the iris hook to the rhexis margin. We just want to engage the pupillary margin, but it is possible if the rhexis margin is close in plane, almost similar plane, just posterior to the iris, you could end up engaging the rhexis margin, and that's what had happened here. So I was quick to diagnose this problem. So I again relaxed the iris hook, injected some more OVD to push the anterior capsule behind, and then engaged the iris hook, and now I have an adequate size of the pupil for me to perform safe phacoemulsification. Same problem can be encountered when you're using a pupillary ring device. So phaco becomes easy, and at this point, you have to ensure that there is no sudden shallowing of the anterior chamber, that because there is already rhexis tear, the posterior capsule that is open. So this viscode is injected into the anterior chamber when I'm in position 0, and then irrigation phaco handpiece is taken out. So cortex is gently aspirated, bimanual irrigation aspiration was done, and here I can see a huge tear, from extending from extremity to the extremity. So I don't know whether it is a wraparound tear or it is the original posterior capsular tear which has extended. So it is not material, it is not very relevant. So I decided to convert from a single piece hydrophobic IOL plan to a 3-piece hydrophobic acrylic, this AR40E lens, which is placed in the sulcus. The optic is captured, buttonholed through the rhexis margin. So here, of course, we have obtained an optic capture, but if capsular contracture happens postoperatively, usually in this sort of eyes, post-vitrectomy eyes, siliconal filled eyes, capsular contracture is quite rapid and quite severe. So there's a possibility of IOL decentration in this case, but I have followed up such cases, more than 10, 11 cases by now, last 20 years. They stay pretty well centered. And the section is always closed because this vitrectomy is died. There's the complications. So section, instead of stromal hydration, we close the section with the incision. So patient has done well in the postoperative period. Now in summary, I'd be telling about certain related issues not pertaining to the case that you just saw. So must remember that rhexis is paramount for safe phaco, and further management options when you have a compromised rhexis depends upon factors which I mentioned here. Surgeon experience is very, very important. If we are a young surgeon, just inexperienced surgeons, just into your phaco career, it is always better not to continue with phacoemulsification. If you know how to do an SICS, go to SICS or bail out to SICS or call your senior surgeon, senior colleague to take over the case. At my level, where I have been doing phaco for more than 31 years, that type of cataract is very important. If I'm dealing with a very, very hard cataract, luminescent cataract, and there's a lot of comorbidities, endothelium is not good, AC is very shallow, and rhexis tear has happened just opposite to on the nasal side where the section has been created, I would not hesitate in converting to a SICS technique. And so you could always refer out in summary or perform a manual SICS or even extra capsular if you don't know how to do an SICS. Phaco can still be performed, maybe at a little anterior plane, and use an appropriate intraocular lens. Thank you so much for your kind attention.